Good morning. Thank you for that kind introduction. So our topic for today is understanding MS progression, which is a very important topic that many of you have expressed interest in and asked me about over the years. And so I think we should just dive right in. So our objectives for today, first, we're going to define terms commonly used in MS. We're going to describe how MS worsens. We'll talk about some of the treatments that have an impact on MS progression. We won't necessarily talk about every single MS treatment available, but the ones that I think are important in this particular area. And then finally, we'll discuss a little bit about neuroprotection, things that you can do outside of disease-modifying therapies. First, to define progression, we think of it as steadily increasing neurological dysfunction without clear recovery. Now, things like fluctuations, some good days, bad days, even superimposed relapses can occur in the context of this steady decline. And you can see on this graph, the timeline we're working with here is really months to years. So it's a very slow, kind of insidious process when we think about progression. One thing that you don't see in this definition is anything to do with MRIs. So MRIs are very important. We'll talk a lot about them in my talk and in coming talks. But for the purposes of my understanding, our understanding of MS progression, it's really based on a person's symptoms and their functional status rather than anything that we can see on an MRI. So to contrast that, we need to understand also what is a relapse. So a relapse is more of an abrupt change, an acute to subacute, meaning over hours to days, episode of neurological dysfunction, which can affect one or more different parts of the CNS, which is the central nervous system, and typically lasts on the order of days to weeks. So you can see the time scale here is different from what we saw with progression, whereas progression is more like months to years. Let me move on. That leads us into what our current understanding is about the different subtypes of MS. So if we were going to be breaking them down, now, to me, it is really all one illness, but we do have these different terms that we use to try to discuss, identify what is going on with this particular person at this moment. And so the terms that we use include RIS, which is radiologically isolated syndrome. That's where MS has been kind of coincidentally found in a person's brain on MRI, for instance, and or spinal cord. But that they don't really have any symptoms suggestive of MS at this time. CIS and RRMS are relapsing forms of MS. CIS is a clinically isolated syndrome when somebody has an initial attack suggestive of MS, though they may not meet all of the criteria to have a full MS diagnosis. Relapsing remitting MS is the type that many of you are familiar with. It's the most common type for people to be diagnosed with. Some 90% of people get diagnosed with relapsing remitting MS at the time of their diagnosis. And that means you would have a relapse and then there would be a period of remission. Relapse and then a period of remission. On the other side, we have the progressive forms of MS. We have primary progressive forms and secondary progressive forms. Primary progressive means somebody has the kind of insidious worsening from the onset of their illness. And secondary progressive means there was some period early on for several years of relapsing remitting disease, and then it transitioned into secondary progressive. So those are the only kind of recognized terms that we have at this moment. In between the relapsing and the progressive forms, there are these subcategories that include primary and secondary progression with activity. And so activity in this case, what we're talking about is relapses or really more like MRI changes that would suggest that there's some amount of ongoing overt inflammation that is detectable. And that becomes important because as we'll see a little bit later on, the progressive MS has been notoriously difficult to treat. To the extent that it is treatable, a lot of that is in people with progressive MS who have some amount of disease activity at baseline. So this is kind of the traditional understanding of the way MS evolves over time. You can see starting out on the left, we have the preclinical phase moving into the relapsing remitting phase, and then the secondary progressive phase. So this is just kind of a schematic. It doesn't necessarily, not everybody has to go through this trajectory. But you'll see that top line indicates brain volume, which we'll hear a lot more about from Dr. Kammeier. Over time, that goes down, also goes down in those of us who don't have MS once we reach adulthood. The clinical disability, you can see that initially there is no disability in the preclinical phase. In the relapsing remitting phase, you can have disability that goes up with a relapse. Now, this is, again, the traditional view. I'm going to challenge that traditional view later on, but this is kind of how we have always understood the relapsing remitting phases. Disability comes in the context of a relapse, and then there's some recovery, maybe not 100% recovery, in which case you can see that one area here where, no cursor, but the second relapse there, the person did not fully recover, and so they developed a new, thank you, they developed a new baseline right up here. So in this view, disability accumulation really happens only in the context of a relapse. And then when you get, if you get to the secondary progressive phase, then the disability accumulation has this more, like upward slope where it's not a discrete event. It's more of this kind of insidious worsening over time. Okay. All the while, you can see the MRI activity at the bottom here, which early on tends to be a lot more. And then over time, years with MS, 10, 15, 20 years, you start to see less and less MRI activity, which again, that's the kind of overt inflammatory activity that has been, among other things, most connected to how much our treatments work. Moving on. Oh, now I have to get out of it. Can I tell you what contrast is? Correct. Yes, I can. Is that on the slide? You mean MRI contrast? Yes. Okay. Well, yes. So MRI contrast is given. It indicates breakdown of the blood-brain barrier, which in somebody with MS, in an MS lesion, we call that an active lesion. So a lesion that contains, or we presume, infiltrating immune cells that are coming in and establishing damage, and that sometimes can have a gadolinium enhancement or contrast enhancement associated with it. It's one way we look for disease activity on an MRI, not the only way. The other way is comparing the overall burden of lesions on one scan to the next scan. And so oftentimes these days, especially in folks who we have on our more highly effective treatments, we don't even get MRIs with contrast anymore. But we can still look for disease activity just based on the comparison of the MRI lesions on the older scan to the MRI lesions on the newer scan. Thank you for the question. Here we go. So this is the expanded disability status scale. It's the most commonly used disability tool we have in MS. It's been used in nearly every clinical trial over the past several decades in MS and many, many observational studies. It basically looks at how functional a person is on a scale from 0 to 10, 0 being completely normal, 10 being passed away or deceased. And in between, you have a score of 2, which would be minimal disability, 3 would be moderate disability, and on until you get to 6, which is a more severe disability to the point that a person needs assistance walking, typically a cane, and then on from there. This scale, like I said, has been used extensively in much of MS research. And so in some ways we're kind of stuck with it. It's not perfect. It does have certain limitations, one of which is that it tends to overemphasize the motor and the mobility aspects of MS. And so a lot of the worsening that you see here is really worsening in ability to walk. Yeah. And so things like cognition, which can also be affected in MS, aren't necessarily as represented in the EDSS. But it's not the only scale. Oh, no, hold on. Well, let me talk a little bit about confirmed disability worsening first. So confirmed disability worsening, we see this in a lot of our clinical trials. It is trying to establish that somebody has some amount of worsening that's not just an off day. It's not just a temporary fluctuation, but it is a persistent worsening. And so you can see it at the on the top, somebody goes from an EDSS of 2 to 3 over the course of 6 months. And then 6 months later, that is still present, that elevated EDSS. So that would be a confirmed disability worsening, or a CDW. By contrast, the one on the bottom, they went up to a 3, and then by the following time point, they went back down to a 2. So that would not be a confirmed disability worsening. So this is an important concept later on when we're talking about different treatments and how well they work. So as I was starting to say, the EDSS is not the only tool that we have to measure progression or disability worsening. We also have other tests, including this one, the Multiple Sclerosis Functional Composite, which is composed of 3 separate tests. One of them is the PASAT, which is a particularly challenging test where you're trying to add the last 2 numbers that you hear and come up with a total, and then continue to just add the last 2 numbers that you hear. So not getting a running total, but just the sum of the last 2 numbers. And so it's a test of working memory processing, and it's in this case the only one that we have that really measures cognitive function. The 9-hole peg test is a measure of upper extremity function. We use that to so the person takes 9 pegs and they try to place them in these 9 little slots and then remove them from these 9 little slots as fast as possible. They do it on a couple times on with each hand. And so it can be particularly challenging for folks who have weakness in the hands or lack of coordination. And then there's the timed 25-foot walk. Some of my patients here, I might have had you do this in the clinic, where it's basically just walking down the hallway 25 feet, and I'm sitting there with a stopwatch or my phone timing you. And so that, I can do during a standard office visit. A lot of these other things, it would take a lot longer. Your appointment would be much longer, and you'd be much more frustrated at the end. So a lot of these tools we use really more in the context of clinical research as opposed to just routine patient care. This is from a study about 10 years ago, more than 10 years ago now, out of France, Rennes, France, where they looked at their whole cohort of patients and who was actually worsening over time. And what they found is using the EDSS, there were 2 separate stages for how people worsened and the time course over which people worsened. So in the first stage, which is depicted by the blue lines at the bottom, there were several different trajectories between being completely without symptoms, an EDSS of 0, and an EDSS of 3, or moderate disability. So people took varying amounts of time to reach that level of dysfunction, and that depended on different things, including age at diagnosis. So the younger people people who are younger at diagnosis tended to take longer to reach that milestone. In this cohort, men tended to reach that milestone a little bit faster than women did. depending on the kind of initial relapse that you had and your recovery from that. So if you had a particularly bad relapse to start and you didn't recover very well, then you were more likely to have a quicker escalation to that EDSS of 3. But on average, once people hit that EDSS of 3, none of those factors mattered in terms of how long it took to get to that EDSS of 6 level or needing a cane for walking. On average, those people, between the EDSS of 3 and EDSS of 6 in this cohort, it was about 6 to 9 years. And so this really was an important paper in our understanding of this kind of progression in 2 stages, where the initial earlier stage, various things could influence the rate of that, and then in the later stage, not as much could influence, or really nothing could influence that rate. Which leads me to this concept of PIRA, or progression independent of relapse activity. Some of you have heard us talk about this concept before. This is really was developed to try to distinguish worsening associated with a relapse, or raw relapse associated worsening, from the kind of insidious progression that I've been kind of trying to get at right here. So this is one way that we're trying to clinically understand what's going on. How are people getting worse that's not related to a discrete relapse episode? And as I showed you in that initial slide, we had this traditional view that that relapses, that people in the relapsing remitting course would only accumulate disability through relapses, although that is not the case, as you'll see in the next slide. We have in various cohorts estimated that PIRA can occur in between 6 and 28% of people, depending on the cohort, depending on how long they're being observed. But overall, it's estimated that it occurs about 3 to 4% per year. So not an insignificant amount. So this was a recent paper from Lublin et al. Looking at how people got worse, whether it was through PIRA or whether it was through relapses, depending on which type of MS they had. So they used a very large database of people with MS, about 27,000 people. And you can see broken down in the upper left, by far the most people in this data set had relapsing remitting MS. And in the lower left-hand corner of that box, you can see the number of people who had any kind of confirmed disability worsening, or CDW. So it was relatively low. So people in the relapsing remitting phase generally don't have that much worsening, especially in the modern era where we're treating everybody with, disease-modifying therapies, especially highly effective disease-modifying therapies. But some still did. And you can see that even in the relapsing remitting phase, the majority of that worsening was the light green, which was progression independent of relapse activity. So not through relapses or raw, as we kind of traditionally thought. And then once you get into secondary progressive or even primary progressive, there was far more percentage-wise of disability, of clinical worsening. And there, the vast majority of it was through PIRA. Move on. And then they also looked at pediatric MS, which kids can, of course, be diagnosed with MS. Thankfully, it's relatively rare. But in kids with MS, when they did have confirmed disability worsening, which, like in relapsing remitting MS, was relatively rare, but when they did have it, the vast majority of that was through relapses, not through PIRA. And in fact, there are people who believe that PIRA doesn't really occur in pediatric MS, that it's all, any worsening is based on relapses. This was an important pathology paper from about 10 years ago that looked at the different types of MS and what types of plaques that they had in their brains. And so you can see on the left, you have mono or clinically isolated syndrome, that initial demyelinating attack, and then relapsing remitting MS. And these are all, by the way, autopsy studies, so people who died not necessarily from MS, and somebody looked at their brain under a microscope. But what they found was different distributions of lesions depending on what type of MS they had. So much of those lesions in the CIS and the relapsing remitting group were acute active lesions, okay? But then once you got into the secondary progressive phase, and especially the secondary progressive phase, the minus is without activity, then you saw really a predominance of inactive and smoldering lesions, okay? So smoldering lesions are going to become more important. And you're going to hear a little bit later on about a particular type of smoldering lesion, a PRL, or paramagnetic rim lesion, I believe in Dr. Alvarez's presentation. But that, we think, becomes a lot more important when we're talking about PIRA, or progression in the context of without any overt inflammatory activity. So this is going to be a pretty busy slide, but you will have it, I believe, in your packets. And also, again, you can download it afterwards. So if we were to kind of try to distinguish pathologically between progressive MS and relapsing MS, we can look at a variety of different things, including where the lymphocytes are. So in progressive MS, the lymphocytes tend to accumulate in the perivascular spaces and in the meningeal spaces, as opposed to infiltrating directly into the substance of the brain. There tends to not be breakdown of that blood-brain barrier or GAD-enhancing lesions. We tend not to see that as much in progressive MS. You tend to see more of these smoldering or slowly expanding white matter lesions. And there can be widespread neurodegeneration. Okay, and then something, and cortical lesions, which is something that that we've talked about in previous talks, and something that we can see in progressive MS, as well as loss of neurological reserve, which is not actually something you can see, but is something that's more conceptual. We have another slide on that in a few moments. And then compare that with relapsing remitting MS, where you have more of these kind of focal invasions of these immune cells or lymphocytes into the substance of the brain, causing acute plaques, without as many or any cortical lesions, and with preservation of your neurological reserve. And so these are more differences in quantity rather than absolute distinctions. So it's not like we can easily look at somebody's brain and tell what type of MS they have based on how many, cortical lesions they have, or how many white matter lesions they have, or the presence or not of smoldering plaques. It's not that kind of, we don't have that kind of ability yet. Okay, so these are kind of diving down even deeper into why we have progression, even on a cellular or subcellular level. We know that in addition to immune cells being involved, your B and T lymphocytes, we also have other cell types involved, your microglia, astrocytes, and within the cells, we can see things like loss of energy production. Energy is produced in the cells by mitochondria. The mitochondria become dysfunctional. There can be DNA mutations within those organelles that can cause problems. So it actually can, there's all sorts of different things on a cellular or subcellular level that we think might lead to demyelination, loss of neurons, loss of axons, and eventually progression of MS. This slide, I wanted to, this is what we see on an MRI of somebody with MS. So on the left, you have an axial slice of somebody's brain. You can see various white spots on both sides of the brain. These are the white matter lesions, and you can see in the center the ventricles, the lateral ventricles, which are somewhat plump looking, and you can also see kind of larger grooves or in the sulci, or the surface of the brain, which would indicate that there's probably been some loss of brain tissue or atrophy. You're going to hear more about atrophy on the coming talk by Dr. Kammeier, but I just wanted to point out a couple things on this slide. One is that I can't look at that brain and tell you what kind of MS a person has, how they're doing, whether they're progressing, or any of that stuff. Unless I've talked to a person, examined the person, that MRI doesn't tell me really much of anything in isolation. And then the other thing I wanted to point out from this slide is that, when we talk about, how people do over time with MS, and particularly this idea of like worsening mobility, worsening gait, worsening strength in the legs and the arms and the hands, a lot of that stuff may not be related so much to loss of brain tissue per se, as perhaps loss of spine tissue. Brain tissue or brain atrophy is something that we're now starting to be able to measure. Spine atrophy, by contrast, is really something that's limited to the research realm, but especially newer things that we're seeing now as far as like cross-sectional area of the upper cervical spine and looking at that and how people do over time. That seems to maybe even be a better marker for telling us some of these things. But again, not something that we're necessarily doing yet on a routine clinical basis. So some of you have heard, I know I'm reaching the end of my time. Some of you have heard me discuss this before. This is a new concept, or relatively new conceptualization of multiple sclerosis from Stephen Krieger in New York, who kind of sees the nervous system as like a swimming pool. You have peaks coming off the bottom of the pool. These are your MS plaques. If they go above the water surface, then you're symptomatic. It's something that you can feel or the doctor can see. If they're below the water surface, then maybe they're visible on an MRI, but they're not readily apparent. Okay, and then in the different types of MS, you can see, for instance, in a clinically isolated syndrome or relapsing remitting, you might have a relapse in which a new peak forms, goes above the water surface, and you become symptomatic from it. Maybe over time it starts to recede. But if it stays above the water surface, then you have a persistent symptom. If it goes just down below the water surface, then maybe you don't feel it necessarily all the time. But if there's some fluctuation in the water level, then maybe you'll feel it. For instance, if you're sick or if you're under a lot of stress, these are some of the fluctuations or pseudo exacerbations that I've talked about in a separate talk. Over time, we think with progression, there's this gradual loss of the water level, which kind of exposes the underlying peaks. So it's not that you're necessarily developing new peaks, but you're losing this water level and revealing kind of the underlying damage that's already been there. And so in this case, the water level can represent like your reserve, your functional reserve. And we know that over time, there's a loss of that reserve. And we think that that's kind of conceptually what drives a lot of MS progression. So immunotherapies for progressive MS, if you look at the package inserts, you'll see that a lot of them say something to this effect, that they're indicated to treat clinically isolated syndrome, relapsing remitting MS, and active secondary progressive disease. So in some respects, they're kind of indicated for any type of MS. Not primary progressive. The only one that has a primary progressive indication is ocrelizumab. But you can see this a similar kind of formulation with all of our disease modifying therapies, which is not to say that we use them all equally. And especially with progressive MS, we tend to gravitate towards certain ones. So this is ocrelizumab, or Ocrevus, which from their original clinical trial that looked at primary progressive MS, ocrelizumab versus placebo. I believe there's some slides on this with Dr. Alvarez later on. But essentially, when they studied this population, primary progressive MS, they found that there was a slight delay in progression between placebo and ocrelizumab. Ocrelizumab is on the bottom. And so over time, people with placebo got worse, people with ocrelizumab got worse, just that with ocrelizumab, it was slightly less worse than with placebo. Okay, so not a slam dunk, not a home run, but some slight decrease in the risk of progression with ocrelizumab compared to placebo. And if you looked at the MRI data, it actually did a really good job of preventing new lesions and okay job, statistically significant job at preventing brain volume loss, but not really great. But so keep those in mind as we move on to this one, siponimod, which was the second drug to show benefit in a progressive trial. This is a type of sphingosine 1-phosphate drug, which is a S1P, kind of like Gilenya or fingolimod, and there's a couple others that are available to treat MS. These are oral pills, and based on this study, we saw, which is the EXPAND trial, comparing siponimod to placebo in secondary progressive MS. You see a kind of a similar graph here, where there's in both the siponimod and in the placebo arms, there is still this slow progression. It's just slightly slower in the siponimod arm. So it's doing something better than placebo, but it's not like halting all progression, for instance. And again, looking at the MRI data, it did a pretty good job of stopping new inflammatory lesions on the left, and an okay job of preventing loss of brain volume. And then finally, we have the tolebrutinib data, which is hot off the presses. And I believe, again, you'll hear more about this with Dr. Alvarez's talk. But essentially, you see a similar kind of thing, comparing this new medication, tolebrutinib, to placebo. You have a slightly less progression. If you look at the MRI data, it did an okay job with stopping lesions, but actually here, it didn't even prevent brain volume loss at all. And so that even throws into question whether brain volume is the thing that we should be looking at in terms of trying to delay progression. This is a summary slide of some of the recent clinical trials that have been done in progressive MS. The yellow or orange ones are the ones that actually showed statistically significant benefit in slowing progression. The Oratorio study, again, being the ocrelizumab, EXPAND being the siponimod, and the Hercules being the tolebrutinib studies. But what you'll notice about all of these trials, whether they were successful or not, is that the mean age, the average age, was generally in the 40s. And in the primary progressive, it was like kind of, in the Oratorio study, it was even below 45. The EDSS mean was below 6, so it was like between 4 and 5 generally, and that's, you know, still able to walk, so not very, very disabled. And then depending on the study, many of them had gadolinium enhancing lesions at baseline, which if you were to kind of design a clinical trial for progressive MS, what you'll want to try to do is make sure that it's a large study, because if this is a small effect size, we're better able to see that effect with a very large trial. Make sure your average age is relatively low. Make sure your average disability scale is below 6, and try to include as many people as you can who have disease activity or gadolinium enhancing lesions at baseline, except perhaps if you're talking about a BTK inhibitor like tolebrutinib. So this is, you know, to suggest that maybe these drugs are doing something. They do seem to be, but also we're getting better at designing these progressive clinical trials to show small benefits. Very briefly, I will touch on these neuroprotective agents for progressive MS to say that we've had some very good ideas lately that in non-immune-based treatments that initially seemed to suggest that they were beneficial in slowing progressive disease down. But when they were all studied for the second time in larger studies, with the exception of the bottom one, which hasn't had a larger study, we haven't actually seen replication of those findings. In other words, they didn't really seem to do anything. So we're going to keep looking for neuroprotective agents, especially ones that don't affect, you know, immune function like our kind of traditional disease-modifying therapies do. But so far, we haven't found that perfect one that you can take that will be, you know, that's been validated to slow progression down. And then finally, I think this is my last slide. There's other things that people can do, lifestyle factors that I think honestly probably have as important a role as any disease-modifying therapies do in progressive MS. And those include things like adhering to a healthy diet. There's been some interesting recent research that showed that higher levels of fish consumption actually correlate with lower disability down the line. And then tobacco use, of course, is bad generally because it'll shorten your lifespan. But in particular, in an MS context, it actually has been clearly proven to make MS worse. And so if you do smoke or use, or probably vape or any other form of tobacco consumption, it's best to try to quit that. And then also medical conditions. We know that certain medical conditions are more common in people with MS, and that also having medical conditions, psychiatric conditions, sleep disorders, things like that, that are not addressed, not treated, can just lead to people doing worse, over time. So whether that's specifically because of the MS or not, it's kind of hard to say sometimes, but definitely if you have any of those things, make sure you're getting them addressed by the appropriate person. Okay, and I think that's all the slides I have. Sorry, I went a little bit over, but I thank you very much for your attention, and I look forward to your questions.